Our mission is to empower patients who are burdened with the disease of morbid obesity to help them overcome that disease process. One of the saddest things about morbid obesity is that the majority of our patients think that it is an affliction that they should be able to do something about on their own. And they're told by so many authority figures that they should just diet and exercise and then it would cure it, and that's not true. It's a disease process. What we're able to do is give them a tool with which they can be successful at helping to resolve the disease and all the comorbidities, all the diseases that go along with it.
So basically, bariatric procedures could be really categorized into two categories. And essentially, they lay on a spectrum. So we have restrictive or purely restrictive procedures, and the idea behind those is that they restrict the number of calories that you can eat, and thus by restricting the calories, you lose weight. These could be things like the adjustable gastric band, the intragastric balloon, which is on one side of the spectrum. As you move up and essentially the surgery becomes more effective at losing weight, you have a combination of procedures which combines restrictive as well as malabsorptive. So on that end of the spectrum would be something like a Roux-en-Y gastric bypass or something like a duodenal switch. As you move from the restrictive procedures to the restrictive and malabsorptive procedures, the weight loss or the effectiveness of these surgeries become much better. So the weight loss will obviously be far more enhanced. The risks will certainly go up as you move from the restrictive procedures to the malabsorptive procedures. However, if we were to talk about overall bariatric risks, so out of 60,000 patients that were reviewed from the ASMBS, which is the American Society of Metabolic and Bariatric Surgeons, Centers of Excellence, which we are one, so we are a center of excellence for bariatric surgery. The mortality risk or the risk of death within 30 days is less than 1 in 1,000.
We were the first in town to pursue these procedures laparoscopically. Our accreditation we've had for many years through the ASMBS with initially a Center of Excellence designation and now what we call a MIPS equipped designation. Our accreditation says that we're good at what we do, we have good outcomes, low complication rates, and good patient satisfaction.
The changes are significant. And the way I actually get this is directly from my patients, direct feedback from the patients. Things that are simple to maybe, to you and I, like tying your shoes. My patients tell me they were not able to do that.
I struggle with my weight all my life. I have other family members who have had bariatric surgery and wasn't sure if that would be an option for myself. I had tried a few times in the past unsuccessfully, and when I was referred to Memorial, they were incredibly helpful, and they actually were able to make it happen for me, and I didn't think it could. When I got the phone call and they let me know that, that it could be an option for me, I felt hope for the first time in a while. I felt like there were possibilities for me that I had written off for myself for a long time. I had the gastric sleeve. When I walked into the bariatric center here, I weighed 535 pounds. I did follow the pre-op diet pretty closely, and my surgery date, when I walked in that morning, I weighed 481, so I had lost about 50 pounds in about 3 months. As of today, I'm at 209. And so I would say it was very successful. And a big part of that for me has just been having really good support. But it's completely changed my life. I had spent years avoiding a lot of things because I knew I couldn't fit. I can exercise and do things that I enjoy now that before weren't even an option for me. We went to a theme park recently and I rode every single roller coaster just because I could. And I didn't think that I would have that in my life. I honestly had written that off. Even down to sitting in a booth at a restaurant, I knew I couldn't do that. And within, I think, 2 months of surgery, I sat in a booth, and I remember I sat down and cried, just tears of joy, because I mean, it's just little things like that you get so used to navigating around, because it just isn't a possibility, and suddenly those little things are happening, and it just it gave me a feeling of freedom, for sure. And I'm still at a place in my journey where my size is continuing to go down.
For me, it was a mental thing. I did not realize until after the surgery how much I disrespected food. I had surgery February 18th, 2015. My husband had his bariatric surgery February 25th, 2015. He's down 115 pounds. Everybody was more than willing to be helpful. Everybody was more than willing to make sure that I was comfortable. And it was the same for my husband. It was the same for my daughter. Everybody had the same great experience. She had the sleeve. She lost her 80 pounds, and she's 135 pounds. And even outside of the people here, we have this, Gloria Ann has this set of people who meet every month. Every month they pick a restaurant. Those people really don't know you, but they still support you all the same. Like some faces are familiar and some people are new, but it's still a support system. And honestly, when we come here for appointments, I can go to my appointment upstairs and leave, but I don't. I come in every time and I speak to everybody in the office, because whenever I need them, they always pick up the phone. And if I can't get them on the phone and I email them, they email me back.
We have a comprehensive program here. We were the first comprehensive bariatric surgical program in this part of Florida. And so it involves our bariatric surgery center at Memorial Hospital with our bariatric dietitians. We offer support group meetings. We help prepare patients before surgery for the procedure. And then, of course, I'm more involved with the surgical aspect, which is the surgery itself. But then afterwards, we have a dedicated program to helping folks be successful with their surgery. When I first started doing this in 2003, I used to get excited about folks when they come in would dwell on their weight loss. And then what we realized with time is the weight loss is not what's important. It's the quality of life. It's the fact that they're healthy, that their blood pressure is better, their diabetes is gone, that they can, they can bike, they can run marathons, they can just do what normal healthy people do.
It's just seeing the patient happy, and happy to have lost weight, happy to get rid of some of the medications they were taking, and happy to be able to play with their grandchildren and tie their shoes and sit in a normal chair. It encompasses everything, and it happens relatively quickly, and so it's very satisfying to see patients go through that. Morbidly obese morbid is the Latin term for deadly, so it's deadly obesity, and from a numbers standpoint, it would be a body mass index of over 35 with certain comorbidities, which are diseases that are exacerbated or made worse by obesity, or a BMI over 40.
The majority of our patients have a BMI of greater than 40. So this is not just being overweight or being obese, this is morbid obesity. This is an accumulation of excess weight, so much so that's going to cause a whole host of comorbid conditions, disease processes that are going to diminish the quality of life, but also are going to shorten the life.
Extremely common in the obese patient with heart disease, high cholesterol, type 2 diabetes, sleep apnea. All of these we would consider the comorbidities that I spoke about, and all are impacted by weight loss.
The realistic expectations for the surgery are to have the morbid obesity resolved, to reach a healthy BMI, and with that weight loss to resolve the majority of their comorbid conditions. If not to resolve those comorbid conditions, then to help make them a lot easier to control.
The procedures we offer are all laparoscopic. There's the adjustable gastric band, the sleeve gastrectomy, gastric bypass, and the duodenal switch. The adjustable gastric band is the procedure we do the least of. It tends to have the most difficult time for patients in losing weight after surgery. Cons would be a slow weight loss. It can take upwards of 3 to 4 years to lose all of your weight, and requires a little more discipline than the other procedures in terms of your diet and dietary habits after surgery.
The reason why we don't do the lap band is because at 10 years there's overall a 23% success rate, which means conversely that there's a 77% failure rate. The most common procedure that we do is the sleeve gastrectomy. The second most common procedure that we do is removing the failed band and converting it to a sleeve. What we tell our patients in our seminars, if in 2017 you should be aware of the fact that if you're signing up for a band, you're signing up for 2 procedures, and that's one to put it in and one to take it out. But none of us in our practice do the band.
A vertical sleeve gastrectomy is a restrictive procedure. However, it also has hormonal effect by the way we actually manipulate the anatomy of the body. Anytime we perform a stapling procedure, which is what sleeve gastrectomy would be, then we have some immediate complications and we have also some long-term complications. So some of the immediate complications would be things like bleeding, because anytime we suture, what we call resect, or we cut an organ, we risk obviously bleeding. There's also a risk that anytime that we staple any organ, the staple line may actually fail. And so you may actually have a leak, which is probably what people have heard of. We have become very good at actually dealing with all of these complications. And our supportive treatment has made this procedure very safe.
The vertical sleeve is similar in nature to a band in that it's a restrictive procedure. It relies on the pylorus, which is a little muscle at the end of your stomach, to empty the stomach, whereas the band is sort of converting your stomach into an hourglass where there's no activity within the band. Your pylorus tends to close up and keep that food in the stomach until it's churned up enough to be able to be absorbed, and then it will relax and let the food go on by.
The sleeve gastrectomy is the most frequently performed procedure that we do by far. We've had great success with it. In our practice, the excess body weight loss in 1 year is over 70%. The nice thing about it is it's very easily reproducible. It is done safely, reproducibly. It has a very good, dependable success rate for the majority of our patients. It also has sustained weight loss. There's a very low rate of recidivism or weight regain. It is good at helping to resolve the comorbidities. It has a very it's done as all of our procedures. We're able to do this laparoscopically. Most of our patients are out of the hospital in 30 to 48 hours after surgery. Like all laparoscopic procedures, there's a very rapid recovery. For the most part, folks are able to drive after they leave the hospital, as long as they're not taking narcotic pain meds. They can get in the shower, they can walk up and down stairs, and after about a week or week and a half, they can pretty much get back to their normal activities. One of the most common disadvantages that we run into is that patients who have GERD or gastroesophageal reflux disease may have that exacerbated. If patients come to us already experiencing severe GERD, then it's probably not as good an option. It has a very low incidence of severe complications. The risk of having a staple line leak is less than 1% in our hands. On the whole, it's a very good procedure that has very predictable, as we said, reproducible results.
Biliopancreatic diversion with duodenal switch is the most complex operation we do, and it relies on malabsorption or lack of absorption of what you're eating for your weight loss. It has the greatest long-term success rate in terms of losing weight and keeping it off, especially for the group of patients we would call the super obese, or those with a body mass index over 50. The rate of weight regain with that procedure is only about 1.5%. But with complexity comes a little bit more work and dedication in terms of adherence to a proper diet and a vitamin protocol afterwards.
So the biliopancreatic diversion really lays on the other end of the spectrum. It's a very powerful tool with regards to weight loss. Again, the immediate complications are the same because it's a stapled procedure, and it's also a malabsorptive procedure because we're rerouting the small intestine. So there is a risk of bleeding, there is a risk of infection, and at the same time, there's a risk of staple line failure. Again, those are the immediate risks. And for most of these risks, we will control them in the operating room, as in we will never leave the operating room without having a perfect operation, essentially. Should these complications occur, again, we have actually really developed a huge arsenal of interventions that we can control all of these complications should they occur. The other risk of biliopancreatic procedure, and is specific to it, is actually malnutrition. Because we are causing malabsorption of the gastrointestinal tract, then the risk of having low proteins and also not being able to absorb enough calories is there, which means you really have to be very compliant. You must keep all your appointments with your clinician, particularly your surgeon and your dietitian, so that we can monitor the level of your vitamins, as well as seeing your overall physical ability and making sure that you're meeting your micro and macronutrient requirements.
All of our patients that we operate on get put on a vitamin regimen. And so they all take vitamins, calcium, B12 supplements, and we depend on them to do that. So in terms of dedication, they come to the program knowing that's going to be part of what their post-op care is.
The gastric bypass is the procedure that we have done for the longest period of time. We began doing that in 2003. It's still considered by the ASMBS to be the gold standard for bariatric surgery because it's what has been being performed the longest with great success. We do not do as many gastric bypasses as we once did, primarily because the sleeve is such a straightforward, simple procedure, and then the duodenal switch is such a robust procedure. The bypass is extremely useful for patients with severe GERD who need weight loss surgery. It also has a very good percentage of resolution of diabetes and comorbidities, which is why we do this procedure. With the bypass, we're not going to remove any part of the stomach. We just bypass the stomach. We divide the upper part of the stomach and leave a gastric pouch that's about the size of a golf ball. We then go downstream and divide the jejunum, and we make a Roux-en-Y anastomosis very similar to that we do with the duodenal switch. We then bring the one end of the jejunum up to the gastric pouch, and we make a connection or an anastomosis between those two, what's called the gastrojejunal anastomosis. So patients will eat a small amount. They fill that pouch with about a golf ball sized amount of food. The opening between the stomach pouch or gastric pouch and the jejunum is approximately a ½ inch. So once they eat that small amount of food, it's emptied slowly into the jejunum. There is an area between the gastric pouch and the anastomosis where there's only food, much like the duodenal switch. There's just food. There are no digestive enzymes. And then downstream, when the digestive enzymes come into play, we then have a fairly long common limb where all the absorption takes place. For the gastric bypass, we have restriction as well as an element of malabsorption, very similar to what we see with the duodenal switch.
The gastric bypass lies between the sleeve and the laparoscopic duodenal switch. So the risks are again the same: bleeding, infection, staple line leak, and the interventions are essentially the same for either, for just as we did for the sleeve and the duodenal switch. The malabsorption deficiencies is less than the duodenal switch. So it lays, if you look at the spectrum where we have a sleeve on one end and the duodenal switch on the other end, the gastric bypass is in the middle. And as we go from the sleeve to the duodenal switch, the weight loss is going to be greater. So that's why you get, an increased risk of having nutritional deficiencies. Again, the way we control this is by keeping a close eye on our patients and making sure that they see us and they see our dietitian to make sure that they're actually meeting their micro and macronutrient requirements.
Once our patients reach out to us, either by coming to a seminar or taking the online seminar, we will see them in the office and examine them, discuss their treatment options with them. Preparation for the surgery is important. We want to make sure that they are seen by at least their primary care physician and any specialist that might be required based on their personal medical history. A lot of times folks are seen preoperatively by the cardiologist, pulmonologist, endocrinologist, or gastroenterologist most commonly, in addition to the primary care physician, to make sure they're medically prepared to have what is a needed surgery, but it's still done electively. So we want to make sure that when they come to surgery that they're in tip-top shape to have that procedure done. Everybody would like to have a magic pill. We don't have that. This requires a commitment. What we say is we have a commitment to our patients. We require a similar commitment from our patients for us to have that same goal of helping them to resolve their disease, to help them be cured of this disease. It is, I like to tell folks, it's not a sprint, it's a marathon. And so it is a prolonged period of losing weight and then of helping to maintain that weight loss. It requires a dedication to following the dietary regimen, and the dietary regimen is not onerous. It's basically just making sure that you get your protein in, and if you get an adequate amount of protein, there's not going to be a lot of room for the things that you shouldn't eat. Make sure that you take your vitamins as recommended and prescribed. Keep regular follow-ups with us, and we also recommend attending the support group meetings if folks are able to. And basically getting enough exercise, living an appropriate lifestyle. It's a lot easier after that weight comes off. And of course, the people that we see are people that have already made a commitment to living healthier and to living better. We're just going to help them do that. We're going to help augment that process.
Oftentimes, patients think the surgery is the be-all, end-all. And although surgery is a huge, big deal, it's only part of the process. There's education that goes on, psychiatric care that goes on, support groups, all in an effort to help the patient through the process so they can have a successful outcome.